So I think we'll start up again for the last 2 hours. So the first case is a 33-year-old male with a testicular mass. And so what we can see here is it's a teratoma, postpubertal type teratoma, which means malignant teratoma. We have a little island of cartilage. It has cytologic atypia, but it's not a large expansile mass, so just part of the postpubertal teratoma, not somatic malignancy. But then we come into this large area, and it's hard to say, but assume this is a 4x field, 5 millimeters. So this is sheeting out. There's no intervening other teratomas component in it. And when you look at it higher magnification, you don't even need, myogenin or desmin. This is rhabdomyosarcoma. So this is a rhabdomyosarcoma rising in a teratoma. And if this metastasizes as a rhabdomyosarcoma, this will not respond well to germ cell therapy. It may respond to rhabdomyosarcoma therapy, but typically not as well as rhabdomyosarcomas that occur outside of the testis. Now, this testis also had another area. So actually, let me go back. Somebody asked a question, what if you see an area that, looks like immature neural tissue that's not greater than a 4x field? So, for example, on this slide, we have these immature neuroepithelial tumor, or area of the tumor, which makes these true rosettes. But this is not greater than a 4x field. But that's still abnormal. It's more than you usually see in postpubertal type teratomas. So this would be the kind of case where you would want to put through more sections to see, do you get areas where it does sheet out greater than a 4x field? So here, for example, we now have like a larger area of this immature neuroepithelial lesion. This used to be called a PNET, arising in a teratoma. As I mentioned yesterday, we now call this embryonic neuroectodermal tumor because they're not entirely analogous to PNETs. They don't have diffuse CD99. Molecularly, they don't have the translocation you see with PNETs, but they still look identical to what you would see with the central nervous system tumor PNET, with this immature true rosettes lined by these immature kind of small blue cells. So this is a somatic malignancy arising in a teratoma where we have two somatic malignancies, both rhabdomyosarcoma and embryonic neuroectodermal tumor. So here's a case of another orchiectomy. And what we can see here is that there's a large scar. And if you go, in the middle of this scar, basically it's just dense fibrosis. But we talked about, differentials of scar in the testes. You could think of trauma, but trauma, number one, there should be a history, a fairly obvious history. The other thing, when you have trauma in the testes, you have massive hemorrhage in the testes. So even when it heals, you should see a lot of hemosiderin if this was an old scar due to trauma, which we don't have. So, it could be an infarct, but it's like a large rounded section, again, an area of scar, that's unusual. So the likelihood is this is a regressed germ cell tumor. So what you have in that situation and you want to look for is other evidence that could support this, that this is potentially a regressed germ cell tumor. So one of the things is you look at the surrounding testis that's uninvolved by the scar. And as I mentioned earlier, with malignant germ cell tumors, the surrounding testes typically looks abnormal. It'll either be Sertoli only pattern or sclerotic seminiferous tubules, but it won't show normal spermatogenesis. So when you look in the surrounding testis here, this is abnormal. It's all mostly Sertoli only with a lot of peritubular fibrosis. So that setting of a scar with all this dense scar with surrounding Sertoli only, again, highly suggestive of regressed germ cell tumor. If this was all I had, the way I would sign it out is scar with dense scar in the testes, surrounding testes, so Sertoli only. This most likely represents regressed germ cell tumor, clinical correlation. But the other thing you want to look for is germ cell neoplasia in situ. Because if you find germ cell neoplasia in situ, you can make a definitive diagnosis that scar was a regressed germ cell tumor. Now, when we were talking about looking for intertubular seminoma, I mentioned one of the clues to looking for intertubular seminoma is to look for lymphocytes, because that's where often it's a reaction to the intertubular seminoma. Similarly, lymphocytes can be a clue that you might have intratubular germ cell neoplasia unclassified type. So most of the tubules in this testis are all scarred down, but we see this little cluster here that's not. And when you go at higher power, this is germ cell neoplasia in situ. So you can see the Sertoli cells, this nice delicate chromatin with a nice central nucleolus. But these mummified dark cell with clearing around them, this one you can start seeing a little bit of nuclear irregularity and some nucleoli. This is germ cell neoplasia in situ. So now we have a scar, germ cell neoplasia in situ, Sertoli only around the surrounding testes. We can say this is regressed germ cell tumor. And many of these patients present actually, as I mentioned earlier, with widespread metastatic disease, but this patient should be followed carefully even if it's not present currently, for the potential of developing metastases down the road.
What are those cells in between the tubules? Are they,
Yeah, those are the Leydig cells. Yep, Leydig cells, yep.
not seminoma?
Yep, no, I think those look like Leydigs. Often when you have a testis that's atrophic, the Leydig cells look like there are more of them because the whole testis is shrunk, so they'll stand out more. So this is another testis. It's a testis biopsy. So the other situation where you will see testes is biopsies for infertility. And there's basically several different patterns that you can see. It's a limited choice. One is normal spermatogenesis. But when we talk about normal spermatogenesis, it's relative to age. So, for example, seeing something with relatively few sperm in an 80-year-old is normal spermatogenesis for an 80-year-old. But if I had that same biopsy in a 20-year-old, I would call it hypospermatogenesis. So when you're looking at the level of spermatogenesis in a biopsy where you do see spermatogenesis, you have to compare it to the age to say whether it's normal or hypospermatogenesis. So hypospermatogenesis is one potential when you look at these biopsies for infertility. And if you do see hypospermatogenesis relative to the age, you should also qualify it to say, is it marked hypospermatogenesis where there's only rare sperm, or, for example, mild hypospermatogenesis. The other pattern you can see is what we saw with the regressed germ cell tumor. You can see Sertoli only. It's also called germ cell aplasia. And then as that progresses, you may see peritubular fibrosis or totally hyalinized sclerotic seminiferous tubules. One of the rarest types of source of infertility that you can see on a biopsy is maturation arrest, which is what this is. So with maturation arrest, the cells mature all the way up to the primary spermatocyte level, but they don't go on to forming mature spermatogonia or spermatogenesis. And so what you see here is basically all these starburst meiotic bodies that characterize the primary spermatocytes, without any spermatogenesis. Now, before you diagnose maturation arrest, you have to be careful because marked hypospermatogenesis, you may mimic maturation arrest, so you have to look carefully for sperm. But typically, even when you have marked hypospermatogenesis, you won't see as many of these starburst type of nuclei. Now, the importance of recognizing maturation arrest, it's one of the few types of abnormalities in the testes that's associated with infertility that's potentially reversible. So when you have hypospermatogenesis, usually you can't do too much about that. If it's end-stage kind of testes with Sertoli only, hyalinized sclerotic seminiferous tubules, nothing can be done. But maturation arrest, if you can identify the etiology, it can be reversed. So, for example, one of the etiologies of maturation arrest is basically increased temperature in the testes. So varicoceles, which are dilated veins around the testes, can elevate the temperature of the testes and cause maturation arrest. If you correct or remove the varicocele, then basically the maturation arrest will be corrected and go on to mature spermatogenesis. The other thing you always want to look at in testis biopsies for infertility is to look for germ cell neoplasia in situ. Patients with infertility are at increased risk of developing germ cell neoplasia in situ. So in all these biopsies, I say whether it's maturation arrest, hypospermatogenesis, normal spermatogenesis for age, but at the end I'll always say negative for germ cell neoplasia in situ if it's absent. Some people ask in terms of should you use Bouwens fixative for testis biopsies for infertility to enhance nuclear detail. In my opinion, a good quality formalin section, you can address the issue of infertility just as good as Bouwens. It's not necessary. Okay, so here we have a renal mass. This is one of the renal masses that I talked about yesterday, so it'll reinforce what we looked at. So it's a pink tumor. That's the first thing we kind of notice. The other thing we notice, and it's pretty much uniformly throughout, I just went down a random field, is we're seeing all these vacuoles. So it's a pink tumor with a lot of vacuoles, eosinophilic tumor with a lot of vacuoles. And if we look at the cytology, it looks high grade. There's prominent nucleoli. If we were to grade this, we would call it grade 3. So this is EVT, eosinophilic vacuolated tumor. Can be associated with TSC mutations or mTOR mutations. And some markers that we use, we have this newer marker, GPNMB, which would be positive in this case. Cathepsin K would be another marker that would be positive. But I think even if you don't have those markers, I think this tumor is distinctive enough in its morphology that you can make the diagnosis purely on the H&E. We call it a tumor, reinforced. At this point, there's never been a metastases, but there's still a rare tumor, so also at this point, we're not comfortable definitively calling it benign. But for those of you who fill out synoptic sheets or CAP sheets, when you deal with these tumors that are not overtly carcinoma, that we don't recognize as carcinomas, you don't fill out any of these sheets. You don't fill out staging sheets. They're not malignant. All you would say is eosinophilic vacuolated tumor. You would give the size, and you would basically give the margins. And that's all you need. So this is an uncommon tumor, but it's a very distinctive tumor in the testis. So it's a 31-year-old male. And the distinctive aspect of this case is the calcification. So some of the calcification here looks almost just like bone, calcified bone. But some of the calcification, let me see if we can find a good area. There's one little area in here. Some of the calcification has a very distinctive morphology. It's kind of described as being almost like popcorn morphology or like trees in a trunk with these concentric little rings around it. This is only seen in one entity in the testes, which is a large cell calcifying Sertoli cell tumor. So a large cell calcifying Sertoli cell tumor is a sex cord tumor. It's a variant of a Sertoli cell tumor. And with the two aspects of it that you see, one of these calcifications, again, these very distinctive calcifications like you see here in particular. The other is the cells. And the cells are it's confusing because it's called a Sertoli cell tumor. But if you actually look at the cells in this lesion, they don't really look, particularly like Sertoli cell tumors. They often look more like a Leydig cell tumor, kind of sheets of tumor. You don't find tubules typically in these cases. So you could question, why are we calling this a Sertoli cell tumor? Why don't we call it a Leydig cell tumor? The reason why we call it a Sertoli cell tumor, occasionally you can see tubules, and also sometimes you can see an in situ component to these lesions involving the tubules at the periphery. Whereas a Leydig cell tumor, you never would see an in situ component within tubules because a Leydig tumor is an interstitial process. So the fact that sometimes we see an in situ component within tubules where we see the Sertoli cells, that's why we call this a Sertoli cell tumor, large cell calcifying. Now, there's several things about this case. First of all, Another important reason to recognize large cell calcifying Sertoli cell tumor, it may be sporadic, but it also can be syndromic. It can be associated with Peutz-Jeghers syndrome or Carney's complex. So those are, again, important to recognize that this entity, what it is, so patients can be worked up to see if they have those syndromes. Now, as I mentioned before briefly in terms of the lecture, when we have a sex cord stromal tumor, we also have to decide benign versus malignant. 10% of all sex cord stromal tumors are malignant, and it's a multifactorial criteria that we go into deciding if it's malignant. There are 5 criteria: over 5 centimeters, more than 2 mitoses per 10 high power field, any necrosis, atypical mitotic figures, vascular invasion, a lot of pleomorphism, and widespread infiltration are some of the key features. So in this case, when you think of a Sertoli cell tumor, the nuclei are very round and uniform. These nuclei are atypical. So when we talk about malignancy or atypical cytology in a sex cord stromal tumor that potentially would qualify as one of the criteria for malignancy, don't expect to see marked pleomorphism, bizarre cytology. You never see that in sex cord stromal tumors. So the cytology that goes into being malignant is basically somewhat subtle. So for a Sertoli cell tumor, these irregular nuclei that are not nice and round and uniform is enough to say that we have malignant cytology. That would be one feature that would be favoring malignancy. You can see here these cells here are pleomorphic. They're not nice and uniform, oval, round cells, just like a normal Sertoli cell, in contrast to a normal Sertoli cell. So we have that feature that is potentially malignant. And then if we look around in this case, we also have areas here that is necrotic in the center of these nests. That's another malignant feature. Here's even more extensive necrosis. And by the time you start seeing extensive necrosis, almost always in a sex cord stromal tumor, you're dealing with a malignant tumor. And in this case, they're probably hard to show. There was also increased mitotic figures. And this is widely infiltrating. So this is an overtly malignant large cell calcifying Sertoli cell tumor. So it's a rare tumor, and 10% of these rare tumors are malignant, so this is a rare version of a rare tumor. Unfortunately, with malignant sex cord stromal tumors, there is no really good treatment. No chemotherapy works for these patients. Radiotherapy doesn't work. So the malignancy is prognostic. But unfortunately, if these patients develop metastases, there's really not too much we can do for them. As I also mentioned, the best marker by far for sex cord stromal tumor is steroidogenic factor 1, SF1. Much better than inhibin, which can often sometimes be negative in sex cord stromal tumors. And here's the SF1. It's a very nice, clean nuclear stain. Also good for adrenal tumors as well, both benign and malignant. Sure.
What is your approach for small lytic cell tumor that was removed by partial or surgery, and it is showing one of the worst features for malignancy, like for example, very high mitotic rates?
Yeah, so if you have, for example, a lytic cell tumor with high mitotic rate but nothing else bad, I would sign those out as a typical lytic cell tumor, say that it has one atypical feature but lacks the other features of malignancy. And based on the studies in the literature, I would say we would favor this would have a benign clinical course, but close follow-up is warranted. But if it's a partial, as long as they got a negative margin, I wouldn't recommend that they go back, for example, and do a complete orchiectomy. But the other thing I would suggest doing, I'm sure you did it in your case, especially if it was small, but if you had a case with, let's say, 1 or 2 atypical features, not enough to call malignant, I would sometimes make sure you put more sections through to see if you can get something to bump it up to malignant.
It was a very small nodule, so we
Put the whole thing, right. Okay, so here we have a kidney mass. And I'm not sure if I discussed this particular kidney mass. I think I did. So this is a tumor that has various components. One of the components is tubular. You can see these tubules here. And in some of these cases, these tubules are fairly long. So if you look, for example, here, we have these elongated tubules. there's really only one entity in the kidney that has these elongated tubules, which is Mucin's tubular spindle cell cancer. So we have these tubules there that would be good for MTSC. We have these foamy macrophages. We tend to think of foamy macrophages associated with papillary renal cell cancer, but they're not specific. For example, MTSC, very common to see these foamy macrophages as well. The other feature that we're looking for is the mucinous component. And so the mucinous component is basically often just little bubbly nature to this, is both in the tubules sometimes and between the tubules. So here we have a little bit of some of that extracellular kind of bubbly, vacuolated, vacuolated. And if you're not sure if it's mucin, you can actually do an Alcium blue just to highlight the mucin as well. But the proportion of mucin, tubular, and spindle cells can vary in a given tumor. Some tumors can have a lot of mucin, others less. And then the spindle cell component, it's never spindled to the same extent as a sarcoma. Here's some nice mucin. Here you can actually appreciate that it's this very pale blue bubbly material. So the spindle cell component, as I mentioned, is a very slight spindling. It's not really a sarcoma. It's that the nuclei just kind of slightly spindle in kind of a very subtle fashion. But by definition, mucinous tubular spindle cell carcinomas are usually low grade. They are carcinomas because they have been reported to metastasize. But there is a high-grade version of a mucinous tubular spindle cell cancer that has areas that are low-grade and then other areas that have overt malignant features. Special stains, immuno is not really helpful in the diagnosis of MTSC. It's really an H&E diagnosis. But MTSC, as I mentioned, with a lot of the variants, you don't give it a grade. Grade doesn't apply to many of these unusual variants. So if you just diagnose mucinous tubular spindle cell cancer, it's assumed it's low-grade malignancy with rare potential for metastases. Let me see. I think I'm going to skip that. Yeah, I'm going to skip this one. We might come back to it, but for now I'm going to skip it. Okay, so this is a bladder mass. I mentioned how I would discuss one of the variants of bladder cancer. So it's a bladder tumor, very undifferentiated. It's basically just sheets of cells with large open vesicular nuclei, prominent nucleoli. And then you can see this scattering of lymphocytes throughout the tumor. In some areas, it's maybe not overwhelming in a number of lymphocytes. Other areas like here, more prominent lymphocytic infiltrate with these big cells. So this is lymphoepithelioma-like carcinoma. We call it lymphoepithelioma-like carcinoma, not lymphoepithelial carcinoma, because these are not EBV related like a lymphoepithelioma in the head and neck region. And it's important when you have a lymphoepithelioma-like carcinoma in the bladder to note whether it's pure LELC or whether there's conventional urothelial cancer admixed with LELC. And the reason why that's important is a pure LELC is exquisitely responsive to radiation therapy and chemotherapy. And even if it's muscle invasive and you diagnose muscle invasive LELC, they do not have to do a cystectomy. They can try treating it with the chemotherapy and radiation therapy and spare the patient a major surgery. If, on the other hand, it's a mixed conventional urothelial cancer and LELC, they do not respond to chemotherapy and radiation therapy to the same extent, and they should be treated like conventional urothelial cancer. Sometimes it can be difficult when you have a case, if let's say you had just this, to tell if it's large cell lymphoma, for example, versus LELC. Straightforward, then with immunos, you can do a cytokeratin 7, for example, which is labeled as a good marker for urothelial cancer. It'll stain these tumor cells. GATA3 would stain them. And then conversely, CD20, for example, would be negative and CD45 negative. This is a pelvic lymph node. So the patient had conventional prostate cancer, metastatic prostate cancer, so that's, not a problem. And if we look around here, some areas of the tumor, look like, pretty conventional, wait for this. But looks like, pretty conventional prostate cancer. The nuclei are fairly uniform, prominent nucleoli, but, you would recognize this as prostate cancer, wouldn't be an issue, especially somebody who has a history of prostate cancer. But then if you look elsewhere in this case, you can start seeing, even at lower power, that there are areas in this tumor that do not look like prostate cancer. So this, even for high-grade prostate cancer, this is way beyond the expected morphology. Very pleomorphic. You'd think more urothelial cancer as opposed to prostate. So this is pleomorphic giant cell adenocarcinoma of the prostate. So very rarely, we did a paper on this, a couple papers, very rarely prostate cancer can have these pleomorphic features. Typically, the entire tumor is not pleomorphic. It's a component of an otherwise more typical prostate cancer. But with this degree of pleomorphism, you want to flag these cases as showing focal pleomorphic giant cell features. The importance of that is that once you see these pleomorphic giant cell features, these tumors have a horrible prognosis. Most of these patients are dead within 6 months to a year. When you do prostate markers, any of the markers that I've talked about, PSA, NKX3.1, P501S, typically these big bizarre cells will be negative for prostate markers. They're just so undifferentiated and pleomorphic. And the more conventional component will still retain the prostate markers. So when you have a case like this and you see this component, the fact that these might be negative for prostate markers shouldn't be concerning. You don't want to diagnose, two different types of tumors, bladder cancer, for example, plus prostate. This is still consistent with prostate cancer. So this is a kidney tumor in a 55-year-old female that ends up being pertinent, as I'll talk about. And so what we have here, I'll show you a couple slides. It's a solid mass. This one isn't particularly cystic. It looks more solid. And we see a few things that are very distinctive in this tumor. So we have areas like this. So if you had this in the breast, what would you be thinking? That's fibroadenoma, or fibroadenoma-like foci, right? So there's very few things, hardly anything in the kidney tumors that have these fibroadenoma-like areas. And the one tumor that does is mixed epithelial stromal tumor, MEST. So seeing this tubular component, we know this is a MEST. Now, MEST is often very cystic. We tend to think of it as more of a cystic and solid tumor. But MEST has a tremendous variation in its histology. Some MEST can be almost all solid, like we see here in this case. And the tubules in MEST are always Pax8 positive. Some of them probably represent native tubules that have been incorporated in the lesion, but nonetheless, once they're in the lesion, it's intrinsic to the lesion. Within MEST, you also have these thyroid-like follicles, like end-stage kidney disease. That's another tubular proliferation that's common in MEST. And then if we look at another slide, we also have in this tumor fat. So there's very few lesions with fat in the kidney. Obviously, we think of angiomyolipoma having fat, but one of the other lesions that can have fat is MEST. You can see smooth muscle in MEST, fat in MEST as some of the mesenchymal component. The epithelium, as I mentioned, can be fibroadenoma-like, and those little thyroid tubules. We also see these small little nests of very kind of hypercellular stroma. And it turns out when you look at these little hypercellular nodules, this is estrogen receptor. Those little solid nodules end up being ER positive. So in terms of estrogen receptor positivity in the kidney, MEST is definitely one of the tumors, more classic tumors where you get ER positivity. But ER positivity can be seen in other entities in the kidney. It can be seen with angiomyolipomas. It's called AMLEC, angiomyolipoma with epithelial line cysts. They typically have ER positivity. You can also see ER positivity in obstructed kidneys. So anytime the kidney is obstructed, you can get, as a metaplastic process, ER positivity. In renal dysplasia, cystic renal dysplasia, there's also ER-positive stroma. So it's not specific for MEST, but nonetheless, MEST characteristically will have some ER-positive stroma. So MEST is one of the entities that only occurs in female. It's been described in males on estrogen, but other than that rare exception, only female. So if it's a male and you're thinking of MEST, most likely it's going to be a different diagnosis. These are totally benign. The only other thing about MEST is, just to keep in mind, is that it's an unusual tumor that sometimes protrudes as a polypoid mass into the renal pelvis. So it's the only tumor, kind of a mesenchymal-looking tumor, which will have this big mass going down into the renal pelvis. When you see that grossly, you should be thinking MEST. Next case is a very unusual case. So it's a history of a female, 48 years old. She had a cystectomy for chronic pain, and it turns out her bladder was augmented. The next slide, you're going to see colon that looks like colon lining up with the urothelium because they had a portion of colon basically adding to the bladder to increase the capacity. She's basically had a chronic 10-year history of self-catheterization. Her bladder was all contracted. It was, I think, more like a neurogenic bladder. It wasn't getting the urine out. So she was chronically catheterizing herself. And that's important for what this ends up being. So when we look at the lining here, it's definitely very atypical lining. But it looks very squamousy, kind of abundant pink cytoplasm, but cytologically malignant. So there's basically in situ carcinoma in the bladder with squamous differentiation here. I don't think any of this is invasion. I think most of this is still, most of this, that's actually urothelial, von Brun's nest. So I think most of this is just in situ squamous cell carcinoma involving von Brun's nest. So part of the tumor is this in situ squamous cancer. And then here's the colon I was telling you about, that there's some colon here. But then if you go separate away from the colon, let me see which is better to do it over here. And we look at the in situ component, it has a very basaloid look to it, different than CIS. CIS is usually not these very hyperchromatic, high cells with high NC ratio. When we see this type of carcinoma in situ, that's often what we would see, for example, in the uterine cervix or in the anus with AIN3 or high-grade H cell in the anus. It's definitely, again, malignant, this high NC ratio, very basaloid proliferation. There's scattered mitotic figures, no maturation of the epithelium, but again, has this HPV look. Now, it turns out that, and we'll talk about it with another case shortly, urothelial cancer is almost never, and this is the case that's exception, almost never HPV positive. And there have been a lot of studies looking at squamous cancers of the bladder, for example, invasive squamous cancers. They're also HPV negative. So usually, urothelial cancer is just HPV negative. The one time that HPV can be present in a urothelial cancer is in patients with women with self-catheterization over many years, where basically there's HPV from the external genitalia that then get transplanted up into the bladder. So that's what's happened in this woman. She's developed an HPV in situ squamous cell carcinoma, just like analogous to cervix or anus, in the bladder as a result of her self-catheterization. So in this case, we did high-risk HPV in situ hybridization, RNA in situ hybridization. And you can see, these signals here, which is the high risk HPV. But again, regular urothelial carcinoma, squamous cancer of the bladder, HPV negative, high risk HPV would be negative. This is one of these rare types of cases.
Why didn't you do P16?
Yeah, so good question. And I'll tell you why we don't do P16. Because urothelial carcinoma is often P16 positive diffusely. So P16 in the bladder is just not a helpful marker. Cervix it is, anus it is, but not bladder. You could do a P16, and if it was negative, that would help you. But if it's positive, it doesn't help.
So if you don't have an HPV-ish, then how do you differentiate between?
With great difficulty. I would say you have to send it out. Yeah. You could do the P16, and if it's negative, you're good. It's not going to be HPV. But if it's positive, then you're stuck.
That's what we had. We had a case which we couldn't differentiate whether it was urinary bladder going to the cervix itself, it's going to be urinary bladder.
Right.
P16 positive, GAP3 positive,
Right.
we doesn't look on. We don't have HPV-ish.
Right. Yeah.
Stuck.
Yeah. Then you're stuck. Right.
It's different.
Very different. Yep. I agree. The only other thing you can do is, and I'll show a case. We'll talk about it more when I have a case in here exactly like you described. There is something you can do, and we can talk about that. Okay, so this is a hydrocele repair. So let me go. I talked about it briefly yesterday. I'll reiterate. Hydroceles are basically the mesothelium from the peritoneum that then come down around the testes. So all a hydrocele is a mesothelial lined sac that typically gets pinched off from communicating with the abdominal peritoneum, can get filled with fluid. But when you think of this hydrocele, mesothelial sac, it doesn't communicate with the vas deferens or the epididymis or the rete testes because, again, it's just this mesothelial lining covering the testes. So in this hydrocele sac, we see these clusters of blue cells. And the question is, what are these blue cells doing here? And sometimes they can be disconcerting because they look high in C ratio, and blue is a small cell carcinoma, for example. If you did a CD56, these would be positive. That might confuse you further to thinking this is, small cell carcinoma, high-grade neuroendocrine cancer. But what, in fact, these are shed rete testis cells. And we did a paper on this to kind of show that. And you could question, why would you see rete cells in a hydrocele? I just finished telling you that the hydrocele sac doesn't communicate with the rete. What happens with sometimes a hydrocele is it's so large it can get stuck onto the epididymis. And when the surgeon takes it off, it rips open the epididymis, and therefore you get these shed cells from the ductal system that come out in with this hydrocele specimen. So the main thing is when you see these clusters of very hypercellular blue cells, don't confuse them with any kind of a malignancy. They're just normal rete cells. Sometimes you can see sperm associated with them, which is a clue that you're dealing with something from the ductal system. Sometimes the sperm, may not be quite as obvious. In this case, not striking. This is a case of enlarged pelvic lymph nodes at the time of radical prostatectomy for prostate cancer. So at low power, you would think this should be metastatic disease. The whole lymph nodes is totally effaced. And when we go to look at this lymph node at higher power, it's filled with all these cells with this abundant pink cytoplasm, these very epithelioid-looking pink cells. I've seen one of these cases at the time of they found these enlarged lymph nodes at the time of radical prostatectomy. They did a frozen section. It was called metastatic prostate cancer, and they stopped the surgery. But this is not prostate cancer. This is called particle disease. So what this is somebody who's had a hip replacement. So if this is the left pelvic lymph nodes, they've had a left pelvic hip replacement, and titanium and cobalt, which is constantly shed from the hip replacement, breaks off just constantly with wear and tear, gets drained into the pelvic lymph nodes, and you get this marked epithelioid, kind of big xanthomatous histiocytic reaction to these lymph nodes that can cause an enlarged lymph nodes and mimic prostate cancer. And if you look around in these lymph nodes, and maybe hard to see, but for example, some of them here you can see, some of this here you can see this little yellowish structure. That would be polarizable. That's part of the hip there. And you also, if you start looking around, you start seeing black, looks like junk. It looks like dirt. But in fact, here's some other little dirt. Here's some more dirt. But none of this is dirt. All of these black irregular objects are always going to be centered on the histiocytes. You're never going to see it elsewhere over the lymphocytes, anywhere else. This is not dirt. This is part of the cobalt from the hip replacement in these cells. So it's kind of an unusual thing, but a pitfall just to recognize that this can occur, and it's always hip replacement as a reaction to it. So now I'm going to show you a case of a prepubertal type teratoma, and we're going to compare it to a postpubertal type teratoma that also looks pretty benign. And I'll explain again how we can tell the difference. So this patient is 21, so it's definitely postpubertal male in terms of the age and development. And we see this lesion that's very organoid, composed of these. Some of this looks respiratory epithelium. Most of it actually looks, I would say, respiratory epithelium. You have nice ciliated epithelium. It's also very organoid. And by organoid, we mean it's trying to recapitulate the normal organ, and that's why we have this nice smooth muscle going around them, just like you'd see a smooth muscle in the bronchus. Very cystic, no cytologic atypia here at all. We talked about prepubertal teratoma, you don't want to see atypia. And then just as importantly as looking at the epithelial as the tumor, you want to look at the surrounding testis. So when we look at this surrounding testis in this 21-year-old male, it's basically normal testis, normal somatogenesis, not Sertoli only, not sclerotic seminiferous tubules. By definition, we see somatogenesis. There's no germ cell neoplasia in situ. That's the classic pattern of a prepubertal type teratoma, in this case occurring in a postpubertal male. Now, in prepubertal males, typically 5-year-old, 6-year-old, 7-year-old boys, all teratomas are prepubertal type. They're always benign. There's no such thing as a malignant teratoma in a prepubertal male. In postpubertal males, 98% of them are malignant, and 2% are these prepubertal type benign ones. Now, just to compare to this lesion, here's a postpubertal type teratoma that if you just looked at the epithelium, you might think could be a prepubertal type teratoma. So this is, again, a 21-year-old male, an older male. It's also cystic. And we look at the epithelium. It also looks, ciliated. It looks pretty benign. Has some smooth muscle around it. So you could argue, there's a little cartilage here, but that looks pretty benign too. So you could argue, if all you looked was at the tumor itself, you could say, this could be a prepubertal type teratoma. And you'd be right if that's all you focused on. But now let's look at the surrounding testis. And when we look at the surrounding testis, this is not normal testis. And in fact, what we have in the surrounding testes is germ cell neoplasia in situ. So what we can see is, in addition to the Sertoli cells, we have these large hyperchromatic nuclei with the vacuoles around it. So we know that this is a malignant, i.e. postpubertal type teratoma, even though it looks very benign in terms of its components. And that's why before you ever consider diagnosing a prepubertal type teratoma, in addition to looking at the actual teratoma itself, even more importantly is what's going on in the surrounding testis.
Do we comment that they are not malignant when we see the prepubertal?
Yeah, so I would say it depends. Yeah, so I think it's not unreasonable because clinicians probably, I don't think, are as familiar with this. So in a postpubertal male, if I were diagnosing a prepubertal type teratoma, I would say this lesion is entirely benign without potential for metastases.
And you are calling it malignant based on the intratubular.
Yep, because the surrounding testis is abnormal. The only time I will ever diagnose a prepubertal type teratoma is if the surrounding testis looks totally normal.
Even though cytologically it looks benign.
Yep. And I've seen cases like this, widespread metastatic disease. Yep. I've seen cases like this where this morphology of the teratoma is associated with widespread metastatic disease.
And no immature otherwise.
No immature, nothing. Nope, this is fully malignant. So it's a case where there's a disconnect between the morphology and the behavior. So final diagnosis with this would be postpubertal type teratoma. 100%. 100% pure postpubertal type teratoma associated with germ cell neoplasia in situ.
You don't use the word mature or...
Yeah, so that's a good question. So in general, I don't use the word mature or immature when dealing with teratomas in the testes. It's different than ovary, where it is used and it's prognostic. So in testes, if you have a postpubertal type teratoma and there's immature elements, doesn't make a difference. It's malignant. In a prepubertal type teratoma, you typically don't have any immature elements, so that's not an issue. So this is one of the kidney diseases that I talked about yesterday. Just again, will be a nice example to reinforce what I've said. So this is an renal mass and kidney with end-stage renal disease. So we have this tumor. We talked about the definition of sieve-like, this cribriform structure with flattened kind of cystic spaces, small cystic spaces. So that's classic that we see here. The other component is the pink cells. And then finally, oxalate crystals. So this is a classic ACKD-associated renal cell carcinoma. The only other entity in the kidney, and I think I might have one, I'm not 100% sure here, but the only other kidney disease tumor that we call sieve-like, which has these flattened cribriform structures, is renal medullary carcinoma. That's really the only other entity. Doesn't have the pink cells, doesn't have the oxalate crystals, wouldn't occur in an end-stage kidney disease. So it's a totally different tumor, but nonetheless, they share the presence of the sieve-like appearance. Okay, so here's somebody brought up a question about IMTs. And so this is the case. So this is a large bladder mass. Clinically, it was actually extending out of the bladder, no history of prior surgery. So clinically, they thought this was a sarcoma in a 55-year-old. And let's see, we can go to several different areas. The tumor. Okay, so some areas of this tumor have what we call is a tissue culture-like myofibroblastic proliferation. So when we talk about tissue culture cells, we're talking about cells that are individual. They're not all compact together. So a leiomyosarcoma, for example, the cells are all compact. You don't see individual cells. With an inflammatory myofibroblastic tumor, IMT, we see loosely teased out individual cells where you can see these long tapering cytoplasmic extensions coming off of these cells, which is something that's not seen, for example, in leiomyosarc. The other critical aspect of an IMT is that the nuclei are not very hyperchromatic. They can look a little pleomorphic, but in general not very dark. They often have that little myxoid matrix. Now, other features of an IMT, some areas that can get a little bit more condensed, like we're seeing here. Other features of IMT, it's common to see these rich capillaries throughout the lesion. It's also common to see sprinkling of inflammatory cells throughout the lesion. These nuclei are not hyperchromatic. They're similar chromatin throughout. Now, mitotic figures can be extremely frequent in IMTs. So, as I've emphasized in multiple entities today, mitotic figures doesn't mean malignant. IMTs can be full of mitotic figures. The one thing that you should not see in an IMT is an atypical mitotic figure. Pretty much anywhere in surgical pathology, an atypical mitotic figure means malignant. However, when you're deciding if something is an atypical mitotic figure, it should be bizarre. It really has to be totally beyond what you could ever expect to see in a normal mitotic figure. But here, for example, we can see readily identifiable, mitotic figures. So this morphology is classic for an IMT. Now, IMTs can occur in two settings. One is called a postoperative spindle cell setting, where, for example, in the bladder, maybe you do a transurethral resection for a low-grade, non-invasive papillary urothelial cancer. 2 months later, there's a spindle cell lesion that pops up in the bladder. That's not what you would expect for a sarcoma. That, with nothing there 2 months earlier, all of a sudden there's a big spindle cell lesion. In that setting, I think it's easier to diagnose IMT because it's just a classic clinical pathological scenario. However, unfortunately for pathologists, most IMTs are de novo, not occurring in a postoperative setting. So you have to be able to recognize it morphologically, not having that clue that it's a postoperative lesion. And the clues that I've talked about, these tissue culture myofibroblastic cells, not hyperchromatic, rich capillaries, sprinkling of inflammatory cells, those are all classic IMTs. Now, IMTs are tumors. They can extend literally. I've seen a resection, a cystectomy for an IMT, where the IMT went out of the bladder into the soft tissue. So it's looks like a sarcoma. And radiographically, this is going to look like a sarcoma. So these are sometimes difficult specimens, because you have two differentials. It's either a malignant spindle cell tumor, like a sarcoma, or a sarcomatoid carcinoma, versus an IMT. One, you do a cystectomy. One, for the treatment for an IMT is you do nothing. Treatment for an IMT is you just watch it. Vast majority of the times, like nodular fasciitis, the tumors will just start shrinking down and scar down. So it's huge differential diagnosis. Some of these patients are young, literally in their teens, so the consequences, again, are just immense. And most of the time, I think you can make a comfortable diagnosis of an IMT in the H&E. Now, 2/3 of IMTs are ALK positive and show an ALK gene rearrangement. And when they're positive, it's like this. The whole thing is diffusely brown. So this case makes it easy. There's nothing else that's ALK positive spindle cell other than an IMT. The problem is 1/3 of the case, the IMTs will be negative for ALK. So you have to be prepared to diagnose IMT even if the ALK is negative, based on the morphology. Now, what I would say is, for the most part, don't diagnose IMT on a limited biopsy, because IMT is myofibroblastic, and you can get things that look myofibroblastic on a limited biopsy that could be just a myofibroblastic reaction to something else, and it's not, the whole tumor is not an IMT. So the only way that I diagnose an IMT is on a full-blown TUR, where I have multiple slides to look at, and I can see it's all IMT. Another pitfall with IMT you have to be aware of is they're keratin positive. So you don't want to get a spindle cell tumor in the bladder that's keratin positive and you diagnose it as sarcomatoid carcinoma. If anything, IMTs tend to be often diffuse keratin positive, whereas sarcomatoid carcinomas are almost never diffuse keratin positive. So paradoxically, diffuse keratin staining in a spindle cell tumor somewhat favors IMT. If you're not sure of the diagnosis, especially on a limited biopsy, basically ask for more tissue. Yeah, so it's somewhat controversial. Let me see. So it's somewhat controversial in that postoperative spindle cell nodule is as I mentioned, there's two different settings you see in IMT. One is in a postoperative spindle cell setting. One is de novo. Some pathologists think they're two entities. One they're going to call postoperative spindle cell nodule if it's a clinical scenario. One they call IMT. Both scenarios, the morphology is the same, the molecular is the same, the clinical behavior is the same. So to me, they're all the same. I lump them all as IMT. I don't diagnose postoperative spindle cell nodule. No, to me, that's just one of the patterns of IMT, or etiologies of IMTs. They're identical, 100% identical.
Do you fish all your IMTs?
I don't do fish, I just do the ALK immunostain.
If they're negative?
If they're negative, typically they're going to be, often they may be negative even by fish. They're not always positive. So again, it ends up being more of a diagnosis on the H&E. Yeah, so it can happen, good question. It can happen in the prostate, but a lot less commonly. The vast majority of cases are bladder. Okay, next case is, I showed an example of that as well, but we'll go through it here. So this is a case where it's a kidney tumor. And if we look at, this area of the kidney tumor, it's pretty classic for a chromophobe renal cell cancer. So we have kind of this lightly eosinophilic cytoplasm. We have the nice plant-like cell borders. We see occasional cells with nice coilocytosis around them, some little irregular nuclei. So perfect for chromophobe. And if it was all like this, as I mentioned yesterday, we don't give it a grade. We just call it chromophobe renal cell cancer. But now let's look at some other areas of this tumor. Now we have other areas of this tumor. First of all, we see areas of necrosis. You never see necrosis in a usual chromophobe RCC, so that's abnormal. We start seeing cells that are more hyperchromatic, that lose some of their nice chromophobe look to them. If we can move it around a little bit, these are all kind of more hyperchromatic nuclei than a classic chromophobe. We're starting to see atypia that doesn't look kind of the degenerative atypia like we see in a chromophobe. It looks more like a true neoplastic atypia. This may be an atypical, looks like an atypical mitotic figure. You wouldn't see that in a routine chromophobe. So this is a high-grade chromophobe. It's areas of the tumor that look like usual chromophobe, but then other areas that are more high-grade. When you actually look what this tumor is doing, it's extensively invading out of the kidney. It's going into vessels with this high-grade cytology. So uncommonly, it's rare, but there is a subset of chromophobes that are high-grade, and you diagnose them based on kind of classic malignant features, high cellularity, true nuclear atypia, mitotic figures, necrosis. And these are the chromophobe carcinomas that have a much higher likelihood of metastasizing. Okay, so the next tumor is a 45-year-old male, and this is a painful paratesticular mass. So when I look at low power, just the low power, you literally, and I've done this with my fellows, I can pick up a glass slide, put it on a white piece of paper, and just look at it and make the diagnosis. You don't even need the microscope. This, at this low power, is an infarcted adenomatoid tumor. Can't be anything else. It's paratesticular, and it's this bluish-looking infarcted nodule. That's a rounded nodule. It has this kind of very basophilic kind of rim around it. There's nothing else. So now let's look at it at a little higher power. And the problem with infarcted adenomatoid tumors is often it's hard to recognize them because they're dead. Now, even in this dead area, you kind of can get an impression that maybe there were some tubules in here that are all dead, but it's hard to be comfortable what's going on there. So let's look a little bit at the outside of the necrotic area. And again, the hard thing about recognizing infarcted adenomatoid tumor is when it's dead, it's just hard to recognize where the tumor is. But when you start coming out here, the key thing what you're looking for an adenomatoid tumor are cells with dense kind of amphiphilic purple cytoplasm with vacuoles. So you should always just, if you think something could be an adenomatoid tumor, look for those vacuoles. That'll be your clue. So cells like this, that's adenomatoid tumor. If you move it around a little bit more. All of these big pink cells or amphiphilic cells are adenomatoid tumor. You can see these cells here with these vacuoles. Those are adenomatoid tumors. But it's hard to recognize it because it's caught up in granulation tissue and reactive stroma due to the infarction. Here again, some more adenomatoid tumor. So the key thing with recognizing an infarcted adenomatoid tumor is number one, recognize that adenomatoid tumors have this propensity to infarct, undergo total infarction. There was a paper by Robin Young on this topic. So once you realize that, and you realize that in this region, if you see an infarcted nodule next to the testis with this bluish look to it, that should be what it is. Then you look to try to find those cells with the vacuoles, kind of in the perimeter. And then finally, you can verify it because an adenomatoid tumor is basically a benign mesothelioma. We don't call them mesotheliomas because they kind of worry the clinician, they worry the patient, and historically these have always been called adenomatoid tumors. But they are, in fact, mesotheliomas. They stain like mesotheliomas, ultrastructurally they're mesotheliomas, but they're totally benign. So if you look in this case, for example, with a calretinin, in the center, everything's dead, so it's negative. But if we look around the perimeter where I was showing you those cells with the vacuoles, you can see that these cells with these vacuoles are all calretinin positive, telling you that this is an adenomatoid tumor. You can also do a pan-keratin. They also light up as well. But, here's a nice example of these kind of nests of cells with vacuoles in them that are picked up and highlighted by the calretinin. Adenomatoid tumors basically are almost always paratesticular, rarely can be intratesticular. They can focally infiltrate into the testes. That's acceptable. It doesn't mean they're malignant. It's also important to recognize adenomatoid tumors potentially at frozen section. So it used to be they didn't do frozen sections for testis mass because they were afraid of seeding the scrotum. Now they've developed techniques where they can take the testes out in a plastic bag, out of the scrotum, take the section for the frozen section, wait for the result, and if it's malignant, then they take everything out. If it's benign, they can spare the testes. So we are seeing more and more frozen sections on testicular masses, and this is one of the situations that if you can recognize that it's an adenomatoid tumor, you can spare the patient from getting an orchiectomy. Unfortunately, at frozen section, you won't have immunostains, so it's more a matter of the knowledge, paratesticular mass. The first thing you should think with paratesticular rounded nodules, think adenomatoid tumor. Okay, this is a cystoprostatectomy and a partial colectomy. You can see a little bit of colon off to the left. Performed for a large mass that was centered in the prostate. So this was considered a primary prostate tumor. The patient's 80 years old. So, typically you'd think it's prostate cancer, but, And what we have here doesn't look like prostate cancer. It's these tubules with clear cytoplasm, and many of them have this dense pink secretion in the middle of this. So if you recall from our discussion on germ cell tumors of the testes, that when you see a glandular yolk sac, the classic features of glandular yolk sac are often tubules with clear cytoplasm, sometimes subnuclear vacuoles, but also these very inspissated, dense pink secretions. So this basically, even though it's in the prostate, this looks like a glandular yolk sac tumor. So totally weird sight, but, germ cell tumors do occur in the prostate. There's been described seminomas, yolk sac tumors. So in this case, you could do several stains. One is an alpha-fetoprotein. Now, as I mentioned, AFP, is a good marker for yolk sac tumor, but sometimes difficult to interpret. So looking at this stain, the secretions are positive, which probably means they're rich in AFP, and the tumor cells kind of have this blush to them, but it's kind of, everything's kind of a little dirty. It's kind of hard to interpret. So a marker that I prefer, as I mentioned earlier, was glypican-3. Glypican-3, in this case, I must admit it's not the best stain either, but it's still labeling the tumor cells, so that's consistent. Now, something else just to be aware of is CDX2. We don't think of CDX2 as a germ cell tumor marker. We think of it as a GI marker. But CDX2 is the most sensitive marker for yolk sac tumor. It's not specific, obviously, but it's the most sensitive, meaning if CDX2 is negative, it's not yolk sac tumor. So in this case, CDX2, diffusely positive as well. So this is ended up being a primary yolk sac tumor of the prostate. The patient was evaluated, the testis is totally normal, just a rare germ cell tumor occurring in the prostate. Now this is another aspect of yolk sac tumor I'll talk about. So this patient had a history of an orchiectomy for a malignant mixed germ cell tumor, treated by chemotherapy afterwards. And 9 months later, there was a biopsy of an enlarged retroperitoneal lymph node. The germ cell tumor was, mixed germ cell, had a little bit of yolk sac, a little teratoma, embryonal carcinoma. And what we have basically in this retroperitoneal lymph node is this kind of undifferentiated sarcoma. You can see these slightly little spindle cells. It was negative for skeletal muscle. It's not rhabdomyosarcoma. Negative for myogenin, desmin. Negative for S100. It's not neural. And so it's negative for all kind of mesenchymal markers. And so what is this sarcomatous component? And one thing to recognize is that most sarcomas, metastatic sarcomatous-looking lesions following a germ cell tumor, it's either rhabdomyosarcoma, like a somatic malignancy arising in a teratoma, like I talked about earlier. But if it's not a rhabdomyosarcoma, the most common source for this malignant spindle cell tumor is sarcomatoid yolk sac tumor. So this is a relatively recently recognized entity that yolk sac tumors can become sarcomatoid. They can be sarcomatoid either de novo or more commonly post-chemotherapy. And the way you make the diagnosis of sarcomatoid yolk sac tumor is somebody with a history of a germ cell tumor where there's malignant spindle cells. Either you can show they're keratin positive or they're glypican positive, or both. But either one is sufficient to call it sarcomatoid yolk sac tumor. CDX2 typically would be positive as well. Yep. So this is a pancytokeratin. You can see not all the tumor cells are positive, but definitely some of them are positive, which would be consistent with sarcomatoid yolk sac, not consistent with some sarcoma, just arising in a germ cell tumor. And more specifically is glypican-3. You can see here, that this tumor, is strongly positive for glypican-3. So this is sarcomatoid yolk that has a horrible prognosis. Most of these patients are dead, typically within a year or so. But a relatively new entity.
Would the alpha C, with the alpha
AFP won't be high in these, no. These don't make,
in serum,
no, not in the serum, not with the sarcomatoid.
metastasis is going to be
Not when it's sarcomatoid, no. Yep.
transformed into something.
Yeah, they lose the AFP production. Yep. So most of these sarcomatoid yolk sac tumors, for example, are AFP negative. That's why you have to use glypican or keratin. Okay, this is a difficult case. It's a transurethral section of the prostate done for BPH. So what we have is, first of all, let's look and find some normal prostate stroma. So if you look here, that's what normal prostate stroma looks like. Smooth muscle. The nuclei aren't very epithelioid. They're not round. They're these small little spindle cells, look very muscly. That's normal BPH stroma. Now we come to this lesion here in the prostate that several things are going on. First, there's a lot of this epithelial proliferation. And if you look at it, you think it is cribriform. So let's look a little bit, higher magnification. No cytologic atypia. Cribriform glands, all these cribriform glands here lack cytologic atypia. So that's prominent clear cell cribriform hyperplasia. I mentioned with cribriform hyperplasia, you often get a very prominent basal cell layer. You can see the nice basal cell layer there, nice basal cell layer there. So we have all this cribriform hyperplasia, but there's also something going on in the stroma. The stroma is not normal. The stroma is extremely cellular. If you look at this stroma, much, much more cellular than normal stroma that I just showed you. This is abnormal stroma. And this is a stump, stromal tumor of uncertain malignant potential. So stumps can have multiple patterns. One of the patterns is having this very cellular stroma, and it's easily overlooked unless you compare it to normal stroma to recognize how abnormal this cellular stroma is. The other thing that you can get with stumps is that stumps induce epithelial proliferations. So there's this epithelial mesenchymal kind of crosstalk between the two components that the stumps induce basal cell hyperplasia, cribriform hyperplasia, this prominent basal cell layer. So that often you end up concentrating on the epithelial component without recognizing that it's actually the background, the neoplastic component of this lesion is actually the stump, the stromal tumor component. So stumps can have different patterns. This is one of the patterns of stump. Another pattern of stump is when you have degenerative atypia. Those are a little bit, I think, easier to recognize. Stumps can recur locally. So after a TUR, they'll rapidly grow back, whereas BPH, if you do a TUR for BPH, it might be 10 years before the BPH grows back. But with these stumps, within 6 months, these things grow back. So clinically, they're very abnormal. Some of them can be associated with sarcoma or can develop into sarcoma. So in a younger man in particular, I usually recommend radical prostatectomy. Older individual, they may follow a patient. Okay, so this is the case that I kept on promising you I'll talk about uterine cervical cancer going into the bladder. So you always have to think about when you have a transurethral section in a woman and you see something that looks like urothelial cancer, you always have to ask yourself, and I always do it because if you don't ask, you'll miss it, could this be coming in from the GYN tract? You just have to ask yourself. Similarly, very pleomorphic tumor in a man that doesn't look classic urothelial cancer, just sheets of tumor, you always have to ask yourself, could this be prostate cancer going to the bladder? Because your bias, your mental tunnel vision, is if you get a TUR of the prostate, you're going to think prostate cancer. You just, or TUR of the bladder, if it says bladder, TUR bladder, you think bladder cancer, you just don't think prostate going into the bladder. You get a TUR in the bladder and in a woman, you're thinking urothelial cancer, you don't think necessarily GYN going into the bladder, unless you ask yourself that question. Now, there are some morphological clues that this is ends up being a cervical cancer going into the bladder. We didn't know any history about that. There was no history. But some of the clues are you don't see an in situ component, and that these nests, number one, look very basaloid, look very blue, even at low power. These are very kind of bluish looks, which is typical of an HPV-related carcinoma, kind of very high NC ratio, similar to almost that the CIS that I showed you in the woman with self-catheterization. That's different than classic urothelial cancer. It just doesn't have that high NC ratio blue look to it. The other clue is that they typically undermine the urothelium. So urothelial cancer can do that, but when you see a tumor like this undermining urothelium everywhere, you should always ask yourself, is this something coming in from the outside? Here again, there's urothelium on the bottom. These nests are down below. Is this an extrinsic tumor coming into the bladder? And always ask yourself that question. Now, again, in this case, we did the high-risk HPV. It was positive. And urothelial cancer is HPV negative. Consequently, we said this patient should be evaluated for gynecological cancer. They worked up this patient. They found uterine cervical cancer. But this was the presenting. And so sometimes you have a history, but sometimes the bladder tumor is the presenting source of the uterine cervical cancer. Now, you asked, what if you don't have in situ hybridization? The other thing that you can do is at least suggest to the clinicians. You can say, for example, let's say in this case, you didn't have in situ hybridization. I would say, infiltrating kind of epidermoid or non-keratinizing kind of squamous cell carcinoma. There are certain features that raise the possibility of a uterine cervical cancer extending into the bladder. Clinical correlation is needed. So at least they don't do a cystectomy for it. They work up the patient for a GYN cancer. So if you can't definitively prove it, at least raise that possibility so they evaluate the patient.
If it was a bladder tumor, you expect to have
Most of the time. There are some times when I've seen urothelial cancer doing this undermining of the normal too. So it might start out with CIS, but then as it goes laterally, it can undermine it. So you could get this picture. So it's not 100%, but it's suggestive of tumor coming out from another site.
Other than the morphology, the lack of CIS.
It's another feature. Yep.
Direct extension.
Yep, from another site. Yep. Yeah, these basaloid nests and the lack of an overlying lesion, yes, absolutely suggest. And sometimes you'll also have it called bottom heavy. So if you have these nests kind of not even close to the surface, but down deeper, that also suggests that it's coming from the outside.
So clinically, the patient presented with what?
Hematuria. Yep.
And they found it now.
They found a mass in the bladder. A lot of it depends which clinician gets it. So if somebody presents with hematuria, they're referred to a urologist. The urologist is going to go up there and not do a GYN exam. They're going to look in the bladder. They see a mass. They think it looks like bladder cancer, and it's up to the pathologist to get the story right. Yep.
Now, if they knew that the patient had a mass, which was infiltrating both the cervix and the
Right.
urinary bladder, they knew that. They just wanted to know which one came first.
Right. And in that case, then you really have to do the in situ hybridization. Yep. Now, do you have? So there's nowhere in Kuwait that you have in situ hybridization? You do have. Okay. Yeah. So yeah, I would send it out, locally then to get it done. Yep. So this is a 45-year-old female with a small 7-millimeter bladder mass. So what we have here, it's kind of an unusual looking lesion. You could argue it's kind of cribriform, but the unique thing about it, if you look at the cytoplasm, it's this very dense, almost granular pink cytoplasm. Very amphiphilic, kind of granular pink cytoplasm, making these little tubules. So let me look around a little bit more. Here are these little tubules. There's some cytologic atypia in here. So if you were just looking at this without your first blush would be you think adenocarcinoma. It's making these tubules. There's a little atypia here, some cribriform glands. Is this adenocarcinoma? But the clue for this lesion is that the cytoplasm has these bright red granules in areas. So I think you can see better here that there's this granular nature to the cytoplasm. And whenever you see in any organ system this very granular pink cytoplasm, you should think neuroendocrine differentiation. And carcinoid tumors of the bladder look different than carcinoid tumors outside of the bladder. The classic carcinoid tumor of the bladder is very glandular, so this is classic morphology for a carcinoid tumor of the bladder with this very tubular glandular morphology and this very amphiphilic cytoplasm. Sometimes you can see atypia. It's kind of endocrine atypia. Doesn't mean it's malignant. The other thing that's unique about carcinoids of the bladder is they're often associated with very prominent cystitis cystica glandularis. So if you look elsewhere in this lesion, this is more just cystitis cystica glandularis, not the carcinoid. For example, up here, all of this up here is florid cystitis cystica glandularis. And that's, for whatever reason, carcinoid tumors of the bladder are always accompanied by cystitis cystica glandularis. Rarely, carcinoid tumors of the bladder can be large invasive tumors, but the vast majority of these carcinoid tumors are these tiny 3-millimeter, 4-millimeter lesions where these patients are undoubtedly cured just by taking them out. And obviously the one stain you want to do to confirm it is a synaptophysin. And you can see it's quite striking. So the carcinoid tumor with that cribriform architecture, tubular architecture, lights up with a synaptophysin. And here's all this cystitis cystica glandularis, that's negative for synaptophysin. And again, why these two are always accompany each other, it's unclear, but it's a consistent finding.
The surface epithelium is normal.
Totally normal, yep. But again, because they look so different than regular carcinoids, if you just not think, if you don't know of the entity, and if you don't know that they're very tubular in the bladder, you just don't think of it in the differential.
In most of the organs, we have gone away from this carcinoid.
Right. You could call this a well-diff neuroendocrine tumor, WD net. That's totally fine. Yeah. This one's a particularly, I think, difficult one because a lot of these well-diff nets or carcinoid tumors of the bladder are very uniform cytology. This one has, I think, more atypia. Again, this is still will behave benignly, but this one definitely could be confused. I think this one was called adenocarcinoma on outside before it was sent to me as a expert contributing pathologist. Right. Yep. Nope. They're very rounded. Exactly right. These are non-infiltrative, very tiny. The other thing, as I mentioned, this was 7 millimeters. You just don't get 7 millimeter adenocarcinomas in the bladder. So that's the other clue. Correlate with the finding cystoscopy. These are just tiny little nodules. Now this is another bladder mass in a female. So again, bladder masses in a female, if it doesn't look standard urothelial cancer, you start thinking, what else could it be? So this is what we had here. There was no history of anything. It was just sent to me as a bladder mass. And we see this basically very cellular, kind of slightly spindled lesion. But even though it was very cellular, just no mitotic activity, very bland, but supercellular. And the question is, what's going on? What is this thing in the bladder? So when I saw this, you could see this is also what I would describe as kind of bottom heavy. So here's our urothelium here. This lesion is, rising deep from the specimen, not near the surface. To me, whenever I see something very cellular, in a female that doesn't have a lot of mitotic activity and very bland, I think of endometrial stromal tumors because that's one of the lesions that can occur. Now you think, what's an endometrial stromal tumor doing in the bladder? That doesn't make a lot of sense. But anyways, we decided to work it up, no history. And, here's the estrogen receptor. I don't have to wait to focus it for you to see that it's, diffusely ER positive. Then we did a CD10. Again, diffusely positive. And then when we found out the history, and this is, at least in the United States, often what we get, the history was a hysterectomy many years ago for something that we don't know what it was. But undoubtedly, this patient had low-grade endometrial stromal sarcoma, and now it's recurred into the bladder. So again, always just have to think, when you have something funny in the bladder in a woman that doesn't fit with any standard urothelial lesion or something that's typical in the bladder, think what else could this be? And I've seen serous carcinomas coming in from the GYN tract. Here's an endometrial stromal sarcoma. Obviously, uterine cervical carcinomas, endocervical carcinomas. All the GYN tumors can manifest as bladder masses.
What's the difference between recurrence and metastasis in this case? How would you
Yeah, I think it's hard to say. It's probably more, it could be recurrence. Yeah, it could be. Yeah, I'm not sure what happened to the person subsequently. Yeah.
recurrence in the bladder? You expect recurrence to occur in the...
Yeah, unless they're doing surgery, they did some spillage or something like that. But yeah. Okay, so this is a bladder tumor, a 59-year-old male, and it's basically just a horrible tumor, very high grade, ends up staining like urothelial cancer. Clinically, they thought it was urothelial cancer, but it just had these giant pleomorphic cells kind of scattered throughout the tumor, much uglier than your normal urothelial cancer. I'm not sure why I did it, but when I see sometimes these very pleomorphic tumors, these are the type of tumors that can sometimes aberrantly express HCG. And we see that not just in the bladder, but you can see it in the stomach and the pancreas. Sometimes you just have these horrible carcinomas, in this case, a urothelial cancer, that can aberrantly express HCG. These are not choriocarcinomas, they're urothelial cancers, but they are, again, so pleomorphic, they just turn on HCG. And some of these patients actually can have such high elevated serum HCG levels, they can have gynecomastia. And actually, it can be a tumor marker for these patients that they can follow them serum HCG, their elevated serum HCG levels, so they can use that to monitor these patients to see if there's tumor recurrence. So there's a spectrum of trophoblastic differentiation in the bladder. One can see papillary urothelial cancers with scattered syncytial trophoblasts, just classic syncytial trophoblasts that are HCG positive. Rarely you can get choriocarcinoma in the bladder, very rare. And then one can also see this, which is urothelial cancer with aberrant HCG staining.
So this will be like counted as a divergent differentiation.
Yeah, exactly. It's trophoblastic divergent differentiation, right? Even in the cases, I recently, last couple months, I had a urothelial carcinoma with choriocarcinoma. There was definitely urothelial cancer and definitely things that look classic choriocarcinoma. And basically the way I described it is that's, in a sense, divergent differentiation from urothelial to trophoblastic choriocarcinoma differentiation.
So we say so much of component is like divergent from the
Right, yeah.
So we get it often, the adenomas.
Sure, and squamous, right, yep. Yeah, no, bladder cancers, urothelial is remarkable for its plasticity and able to show differentiation along different lines, right? This is a prostate, ends up being a radical prostatectomy. And what we see here is that's something that does not look like prostate cancer. Right. So it's a basal cell carcinoma of the prostate with kind of adenoid cystic morphology. The WHO calls all basal cell carcinomas adenoid cystic carcinomas. I think that just doesn't make a lot of sense. And I don't do that because this particular basal cell carcinoma does look like adenoid cystic, but a lot of basal cell carcinomas have no resemblance to adenoid cystic carcinoma at all. They look like basal cell hyperplasia, but malignant and infiltrative. So again, I don't think that's makes a lot of sense. When I asked the WHO, somebody in the WHO, why do they call them adenoid cystic carcinoma? Why change the name from basal cell carcinoma of the prostate? The explanation was they don't want to be confused with basal cell carcinoma of the skin. And I said, if somebody signs something out as basal cell carcinoma of the prostate, how would they confuse it with a basal cell carcinoma of the skin? But the WHO wants to keep certain names only for certain organs, so they want to keep basal cell carcinoma only for the skin. But in the prostate, we have basal cells, and we have basal cell hyperplasia, and so it makes sense to have a basal cell carcinoma. So again, the name change for me makes no sense at all. I still call these basal cell carcinomas. But sometimes it is, yeah.
When you call it adenoid cystic, doesn't it mean that's a poor prognosis?
Yeah, so not necessarily, no. So there's several different types of basal cell carcinoma morphologies. Some of them will look like basal cell hyperplasia, but widely infiltrative. This pattern of basal cell carcinoma, you can have, for example, this type of morphology you never see in basal cell hyperplasia. These variably sized basaloid nests, bigger, medium sized, irregularly shaped. That's not a pattern that you see with basal cell hyperplasia. The adenoid cystic carcinoma pattern with more the cribriform pattern is also something that you never see with basal cell hyperplasia. So this kind of a pattern here, again, you never see with basal cell hyperplasia. This is malignant. Now, basal cell carcinoma with this, there's another pattern of basal cell carcinoma with large basaloid nests with necrosis. Those are the ones that have a higher likelihood of distant metastases. These types of basal cell carcinomas are more problem local infiltration, not so common to have distant metastases. The other thing that you see with basal cell carcinoma and not hyperplasia is a desmoplastic reaction. So basal cell hyperplasia, The little nests of basal cell hyperplasia are just sitting in normal stroma without any kind of stromal reaction. Here we see this myxoid reactive stroma. That also clues you into that this is a basal cell carcinoma. Finally, basal cell carcinoma can have BCL2 overexpression, whereas basal cell hyperplasia does not. And the final stain that sometimes can help is sometimes it can be difficult to tell basal cell hyperplasia versus basal cell carcinoma, is to do a Ki-67. Basal cell hyperplasia, very low, 1%, 2%. Basal cell carcinoma is going to be 20% or more in many cases.
So hypothetically speaking, in a biopsy, you don't.
It can be difficult. There are some cases on a biopsy you can be definitive and call it basal cell carcinoma. If I see on a biopsy these kind of variably sized nests, I will call it carcinoma. If I see a desmoplastic reaction, I'll call it carcinoma. The adenoid cystic pattern, I'll call cancer. But there are some times where I see just the multiple small nests florid throughout the biopsy. I say basal cell proliferation, and I'll say on this biopsy I cannot be certain to distinguish between basal cell hyperplasia versus basal cell carcinoma. Okay, so this is a kidney tumor in a female. And I talked a little bit about this yesterday. So here we see, parts of this tumor, which are classic for angiomyolipoma. So this is, so many of the angiomyolipomas that are resected are what we call fat-poor AMLs. And the reason why they're resected is AMLs that have a lot of fat in them, on imaging, they can tell they're fat and they just leave them alone. They don't take them out. So the ones that we tend to see surgically in surgical pathology tend to be the ones where there's either no fat or very minimal fat. And that's why they're removed. But you can recognize that this is an angiomyolipoma because it has what I call the spiderweb cells, very filamentous cytoplasm, very lightly eosinophilic. You can see these little filaments in the cytoplasm. That's classic for these PEComa cells. So PEComa, perivascular epithelioid cells, are a family of tumors, a sugar tumor in the lung, lymphangioliomatosis, often in the mediastinum, and then angiomyolipomas. In the kidney, I don't use the term PEComa because urologists are used to the word angiomyolipoma. PEComa, they don't know what that is. So this is, a fat, poor angiomyolipoma, not a problem. But then if you come over to here, all of a sudden it doesn't look like angiomyolipoma, and this is what I was referring to as a typical epithelioid angiomyolipoma. You get these big cells that I talked about yesterday called amoeboid cells with these huge amounts of cytoplasm, and then you have to decide, is this enough to call a malignant epithelioid angiomyolipoma or just still an atypical epithelioid angiomyolipoma? So it depends, if you look at several criteria. Is this component here with these big pink cells occupying over 75% of the tumor? Do you see increased mitoses, any atypical mitoses or necrosis? And if those are present, then you call it a malignant epithelioid AML. If you don't have 3 out of those 4 criteria, you call it an atypical epithelioid AML. But it's striking. Sometimes you only get this, and if you're just looking at that, you wouldn't be thinking angiomyolipoma. So you have to recognize that these atypical or sometimes malignant, if it's pure like this, most of them will be malignant epithelioid AMLs, can resemble more like a high-grade pleomorphic grade 4 renal cell cancer. So in that setting, what you want to do is a keratin. These are going to be keratin negative, Pax8 negative, and they'll be hopefully positive for HMB45, melon A, or cathepsin K. But in the past, we didn't think of angiomyolipomas as being potentially malignant. Now we recognize, a subset of them can truly be malignant. And again, you want to separate out malignant AML from multifocal AML. So multifocal AML can involve lymph nodes, spleen, liver, kidney, GYN organs. But malignant AML actually will spread distant metastases to lung and kill patients. It's a totally different phenomenon. This is like a beautiful example of these large amoeboid cells. This was an orchiectomy, just Nice example, I showed you spermatocytic tumor. I'll just show you another example of it, kind of on a slide. But has beautiful, those intermediate cell types with a speckled chromatin, leptotine, spiremic chromatin, pink cytoplasm, some of the smaller, darker nuclei, which are more the erythroblastic cells. And again, those cells that are the least common are the giant cells, and you don't need all three of those cell types to call a spermatocytic tumor. And in this particular case, as I mentioned, one of the frequent things that you can see in spermatocytic tumor, you don't see germ cell neoplasia in situ, but you do get intratubular spermatocytic tumor. That's totally accepted. And despite how pleomorphic these look, I mean, these look worse than seminomas, they just don't metastasize. So we don't call them malignant. This is a kind of a cute case. I had a case just a couple weeks ago that caused a lot of problems. So it's a vas deferens. It was a painful nodule in the groin, no history. And when we look, there are all these tubules here. Here we can see these tubules lined by these cuboidal epithelium, some prominent nucleoli. Some of them are inflamed. And, we kind of these little, here's another little tubule over here. Some of them have some mitotic figures, a lot of inflammation. And you end up saying, what are these tubules? What are all these tubules doing, around the vas deferens? Some of them potentially, in some cases, these can even go into nerves, even go into vessels. But the other thing you look at, in addition to the inflammation, you look at these cells. This is sperm. So what is all this sperm doing with these tubules? So this is vasitis nodosa. So vasitis nodosa typically occurs after vasectomy. So, and what happens with vasectomy is you cut off the vas, take a little piece of the vas out. And then what happens is, just like in arteries, when you have atherosclerosis, you try to develop collateral to anastomose the vessels. When you cut off the sections of the vas, you get a proliferation of all these little tubules that are trying to hook up to each other. Now, a long time ago, when they used to do vasectomies, they would have the vasectomy, take out the piece, and just leave it like that. And they found out some women were being pregnant after vasectomy, and they couldn't figure it out. And what happened was these little tubules would proliferate and join up, and patients would get pregnant. So now when you do a vasectomy, you take out the middle segment, you move this vas deferens, and you put a piece of fascia in between, so when these little tubules proliferate, they can't connect up with each other. But from a pathology standpoint, if you don't know the history of vasectomy, you see all these tubules proliferating around. The potential is to think there's some kind of malignancy. Recognizing that there's sperm is one of the clues. Sometimes you don't see that many sperm. But again, these are very infiltrative little tubules. They can go into vessels, into perineural invasion. But the key is to recognizing that in this site next to the vas deferens, when you see tubules, it's always pretty much vasitis nodosa. Sometimes you also get sperm granulomas reacting to the sperm too, where you get a histiocytic reaction next to the sperm. I've also seen cases of vasitis nodosa without a history of vasectomy due to prior surgery or trauma in the area. So this is a nice case. We talked about clear cell adenocarcinoma. Let me talk just briefly about clear cell adenocarcinoma etiology. So clear cell adenocarcinoma can arise in the setting of endometriosis in women. So here, for example, is a nice little nodule of endometriosis with a little bit of stroma around the center, around the outside, and some hemosiderin-laden macrophages in the middle. And then here we have the clear cell adenocarcinoma. But clear cell adenocarcinoma can also be divergent differentiation from urothelial cancer. So in some cases, you see urothelial cancer admixed with clear cell adenocarcinoma. So it can be, again, this a type of adenocarcinoma differentiation. But nice pattern of clear cell adenocarcinoma. Recognize that you don't always have the clear cells. This one's more pink cells, but it's tubular, tubulopapillary, little hobnail cells. Those are all classic features of clear cell adenocarcinoma. Now, in this case, we have a history of endometriosis. We know it's coming from the endometriosis. But if you get a diagnosis of clear cell adenocarcinoma in the bladder, these are indistinguishable from clear cell adenocarcinomas in the ovary, even in the uterus. So you basically have to say this could be primary in the bladder, but you have to exclude spread from the GYN site. The next case is a large paratesticular mass. So in adults, so in children, when you think of a paratesticular mass, you think of rhabdomyosarcomas. Those are going to be the top 20 choices. But for an adult, the most common paratesticular soft tissue is a well-diff liposarcoma. After liposarcomas, you also get some leiomyosarcomas. Now, in the paratesticular region, if you see a lesion that looks like this, some horrible high-grade malignant spindle cell lesion that looks like a pleomorphic high-grade sarcoma, doesn't look like a leiomyosarcoma, this should be dedifferentiated liposarcoma. And so what you have to do is look into the two things. One is you want to look at the surrounding fat to see if you can find anything that looks like a well-diff liposarcoma component. Here, maybe you're starting to see some of that, but it's a little tricky. That still could be the poorly diff component going out. Let's look at another slide. Here again is this nodule of this very poorly differentiated focus. But if you start, again, kind of going out away from it, more into the fat, you start seeing some of these larger hyperchromatic cells. That's more classic for well-diff liposarc. And then what you want to do is MDM2. So there's two different ways you can do MDM2. One is MDM2 immunohistochemistry. And MDM2 immunohistochemistry is very specific, not as sensitive as in situ hybridization, but it's still specific. So in this case, the MDM2 is positive, so that's diagnostic of a D-diff liposarc. And somewhat maybe paradoxically, D-diff liposarcomas tend to have more MDM2 positive cells than well-diff liposarc. So if you're questioning, is this a D-diff liposarc, do an MDM2, it should be positive. It should be straightforward. But sometimes you might have a negative stain with an immunohistochemistry, and in situ hybridization is more sensitive. I don't usually use the in situ hybridization first. The problem is sometimes it's too sensitive, and even in non-liposarcomas, you can see some staining. So in order for it to be positive with in situ hybridization, it has to be very strong staining, just like we're seeing here. But the key thing is when you're grossing a paratesticular tumor, don't just sample the fleshy, firm part. Sample things that look like normal fat. You don't think of doing that. You think, oh, let's just sample the obvious tumor. But since most of those firm, fleshy tumors are D-diff liposarcs, you want to sample things that look like normal fat because that's where you're going to find the well-diff lipo component. This is a bladder tumor. It's a very kind of small lesion. And the way I would describe this is like if you think of a deck of cards and you have the club kind of on the card, looks like kind of a clover. That's what the silhouette looks like. So it's not papillary. We don't see nice exophytic papillary fronds like a papillary urothelial tumor. This has basically these kind of, again, club shapes overall silhouette with little nests of urothelium in the middle with a fibrous background. This is the fibroepithelial polyp in the bladder. Fibroepithelial polyps can be seen at any age, including children, in the bladder, in the ureter. Important to recognize that these are fibroepithelial polyps and not a urothelial cancer because these are totally benign, no relationship to multifocal urothelial cancers. They can have several different morphologies, but this is one morphology where you get that, again, overall club-like shape and then a lot of little proliferation of bland urothelial nests in the center of these lesions. This is another mimicker in prostate cancer. That's uncommon, but it's an important mimicker. So first of all, we see something that looks very cellular. And when you look at it at higher power, it has several different components. One is we're seeing these kind of looks like little tubules, glands, kind of poorly differentiated glands, sometimes almost just individual cells. If you were to grade this, if you would call this pattern 4, maybe some pattern 3. Here's some individual cells. You might even think, is there some 5 in here? But the most important thing to recognize is not the glands, but look at the stroma. The stroma is very cellular. Prostate cancer, you never see a cellular stroma associated with prostate cancer. So when you see little glands in the prostate or poorly formed glands and a very cellular stroma, you should be thinking of the entity sclerosing adenosis of the prostate. Sclerosing adenosis is the only entity in the prostate that is a myoepithelial proliferation. So in the breast, we have myoepithelial cells, we have myoepitheliomas. In the prostate, we have basal cells. They're not myoepithelial cells. They're not S100 positive. They're not calponin positive, etc. But the only entity in the prostate that has myoepithelial cells is sclerosing adenosis. So in this case, in sclerosing adenosis, in addition to the cellular stroma, which is very important to recognize, the other thing to recognize is that some of these tubules have a hyaline rim of collagen. So the one other entity that we talked about with a hyaline rim of collagen is nephrogenic adenoma. The only other entity in the prostate with the hyaline rim of collagen is sclerosing adenosis. So maybe won't be able to show it as well, maybe here. But sclerosing adenosis, many of the tubules will kind of show that little rim of collagen around it. You can start to see a little bit of some of that little hyaline rim of collagen around some of these glands. So with sclerosing adenosis, whereas adenosis is non-infiltrative, the tricky thing about sclerosing adenosis, it looks like cancer in an infiltrative growth pattern. So I talked about the first lecture of prostate cancer, that when you see, benign gland, and something on both sides, that should be cancer. Most of the time that is, but with sclerosing adenosis, that's not the case. Sclerosing adenosis actually looks truly infiltrative. So again, if you only focused on the epithelium, you might call this a 3+5 or 5+3. But the stroma, again, is your clue. Far too cellular. It's not normal stroma. If you look just here in the normal prostate, that's your normal stroma. Totally different than what we saw in the lesion. And then to verify the diagnosis, you can do an S100 stain or another myoepithelial stain. So if you look at S100 in the normal prostate, some of the muscle is staining, but if you look at the epithelium, for example, let's see, let's go over here. If you look at the S100 here, in addition to staining some of the basal cells, what you can also see is the S100 is staining some of these spindle cells. So these are truly myoepithelial cells and showing myoepithelial differentiation, whereas normal prostate stroma is not S100 positive. This is totally a benign entity, but a pitfall because it can be diagnosed as high-grade cancer. I talked about neuroendocrine differentiation in the prostate, small cell carcinoma. There's another type of neuroendocrine differentiation, which is adenocarcinoma of the prostate with Paneth cell-like neuroendocrine differentiation. So we talked about the carcinoid tumor having those bright red granules. Here's a prostate cancer where there are these similar bright red granules, and these light up with synaptophysin, chromogranin. And these are tumors that have these Paneth cell-like differentiation. Most of these tumors, you don't give them a grade. So if I were to grade this tumor, I would call this 5+5. There's no glandular differentiation. But look how bland this is, almost like a carcinoid tumor, like a well-defined net. So these tumors with Paneth cell-like neuroendocrine differentiation tend to do very well clinically. They don't tend to behave aggressively. Even though their architectural pattern would suggest that you would call them a higher grade. So just an unusual pattern of prostate cancer. Sometimes it's pure carcinoma with Paneth cell-like differentiation. Sometimes you can see usual prostate cancer and see the Paneth cell-like neuroendocrine differentiation more focally. This is, I talked about oncocytomas can have degenerative atypia. This is probably the wildest oncocytoma I've ever seen, in that it had diffuse degenerative atypia throughout the lesion. But you can see the atypia is still this smudgy, degenerative hyperchromatic nuclei. And what you have to do in this case is try to find some kind of more normal oncocytoma, and then recognize that it's an oncocytoma. So if you go up into this area here with a little nest and a fibromyxoid background, and you look there, the nuclei are nice and round and uniform. That's your normal oncocytoma. So there is a background of normal oncocytoma. And then basically you have to then look at all those cells with the degenerative atypia and decide, is this truly malignant looking or more degenerative? Smudgy, chromatin, pseudonuclear vacuoles. If you did a Ki-67, again, very low. This is just very prominent degenerative atypia in an oncocytoma. I showed you an example of a large nested carcinoma. This is a nice slide of it. So here we see in this case, there actually is a papillary urothelial carcinoma on the surface. You don't always have that with nested cancer. But what you can see are these large nests growing down deep into the muscle. Even though these nests are totally bland, cytologically they look like normal urothelium. The fact that these nests are down in the muscle, and in this case they're actually going through the muscle, this is carcinoma. So there, as I've stressed during the talk, there's no benign urothelial process that involves the muscle. It has to be carcinoma. So I showed you a needle with a BPH stroma with those vessels. This is a simple prostatectomy done for BPH. And you can see how extensive stromal nodular BPH can be with no glands. So this is all BPH, multinodular. Some of them will have that thick-walled vessels that you can see here coming out at you. But it's not a tumor. This is just normal BPH. But you can have extensive, here's some of those thick-walled capillaries, but you can have extensive stromal BPH, no glands at all, and it's not a neoplasm. So just be aware that stromal BPH can be that extensive. I showed you a case of a seminoma with pagetoid spread. Here's a seminoma, so, classic seminoma. And then here, at first blush, you might think that's embryonal carcinoma because you're seeing glands. But when you look more carefully at those glands, what you can see is that there are glands that are lined actually by flattened cuboidal epithelium with the seminoma cells around it. So what you can do is if you do a C-kit, the C-kit is going to stain the seminoma, but if you look, all the little tubular cells that are on top of those seminoma cells are negative. And if you do a keratin stain, it's a reverse pattern. What you will see is the keratin is staining the reedy epithelium, but all the little pagetoid seminoma cells are negative. And if you do a CD30, basically all of this is negative. So you can have extensive pagetoid spread of reedy cells, of seminoma cells, into the reedy testes, and you don't want to mistake that for embryonal carcinoma because they look tubular. So just to be aware of that pitfall. And second to the last case is something that we see not infrequently in GU pathology. So it typically presents as what's called a groin mass. It can be down in the inguinal region. It can be in the perineum. It's a soft tissue nodule, and deep soft tissue nodule. And it's a very circumscribed, rounded nodule. It has kind of myxoid stroma, and it has these characteristic big vessels. And characteristically, in these vessels, there's a lot of fibrin thrombi. So here we see all these vessels with fibrin thrombi. We see a myxoid stromal component in here. And this is an example of cellular angiofibroma. Now, the differential is aggressive angiomyxoma. So, and it's a big difference because aggressive angiomyxoma is a locally infiltrative lesion, hard to get around. Surgically, cellular angiofibroma is just a benign thing. You take it out, there's no problems. So how do you distinguish cellular angiofibroma from aggressive angiomyxoma? They immunohistochemically, you can't do them. They are all variably positive CD34, ER, and PR. The biggest thing that you can do is look at low power. Cellular angiofibromas are very circumscribed. You can see how this is a nice rounded circumscribed border. Aggressive angiomyxoma is going to be an infiltrative tumor. Also, aggressive angiomyxoma never has these fibrin thrombi. And also what happens in aggressive angiomyxoma, the vessels have these cells almost like an angiomyolipoma that the spindle cells radiate off of the vessels. But this is a totally benign lesion. And if you, in order to make the diagnosis, once you see it circumscribed, just do an ER or a PR, and if it's positive, then you know you're dealing with cellular angiofibroma. Last case. Is an adenosquamous carcinoma of the prostate. So adenosquamous carcinomas of the prostate are uncommon. They can occur most commonly after somebody has advanced prostate cancer, treated with hormone therapy, with antiandrogens, and you develop squamous differentiation in the cancer. But it can rise de novo. So here we see, for example, a very squamous carcinoma component. Adenosquamous cancer, the squamous carcinoma component can be not that pleomorphic, so sometimes almost looking like a benign squamous metaplasia. But here, for example, it looks like squamous carcinoma. And then if you look elsewhere in this case, let me see, where is that? Here we go. If you look elsewhere in this case, here's an area that looks more like high-grade usual prostate cancer, not squamous. So if you look at the PSA stain, for example, here's that little nodule I showed you that looks like prostate cancer. That's staining with PSA. But the squamous carcinoma component, is not going to label with PSA. It's pure. It's truly squamous cell carcinoma. Similarly, if you do a PIN4 stain, which is high molecular weight keratin and P63, the prostate cancer component is going to stain just like usual prostate cancer, negative for the basal cell markers, positive for racemase. But the squamous component is going to stain basically just like squamous cell carcinoma. So it's going to be positive for high molecular weight keratin, positive for P63, would be positive for GADA, for example, as well. So not to be confused, if you see GADA positivity or high molecular weight keratin positivity in a prostate cancer, it doesn't necessarily mean you have a collision tumor between urothelial cancer and prostate cancer. It could all just be adenosquamous carcinoma of the prostate. Typically, these tumors have a poor prognosis. Adenosquamous carcinomas won't respond to really any typical therapy. And I think that does it, finally. Okay, thank you.